Good afternoon. Thank you very much to Dr. Samin Sharma for this very kind invitation and to the organizing committee. When I was landing yesterday afternoon with this big Airbus 380, I was thinking to this story that all of you know of this pilot who landed in the Hudson River with and saved the life of many passengers when he had two engines blocked by birds in New York. So we have sometimes the same situation to find. All of you know that we have sometimes to save the life of only one patient, and the pilot it's several passengers. But I have selected for that to show you a nightmare, because I think it's really in this situation that we can really learn. So it was an unexpected nightmare, of course. I have no disclosure for this presentation. It was supposed to be a simple case, even if you will see it was a distal left main, but 68 years old, male, smoker, non-diabetic. He had, anyway, a previous history of coronary disease. He had 2 stents on the proximal LAD and the mid LAD a few years before, and he was in stable angina. So this is the left angiogram. Definitely there is a calcified distal left main that you can see with tight lesion both on the ostial or the LAD and the circ, but the distal LAD is 100% blocked after the second stent. So we were thinking that it was feasible to do angioplasty with rotablator because of the calcification. The right was also diseased, but the overall syntax score was 30. So we discussed with the surgeon, and he said the distal LAD is 100% blocked. Let's go for the PCI first. So the approach of the colleagues who did the procedure was a right femoral. We use an extra backup from Medtronic, 3.75. The patient was preloaded, of course, with clopidogrel and aspirin. And first of all, we couldn't cross the circumflex with the Rota Y, and we also tried to cross with many other Ys, probably because we underestimate the angulation and the severity of the proximal ostial circ stenosis. So the operator decided to go to the LAD. He put a Y in the diagonal because of the distal LAD, and thinking that probably the anatomy will be changed by debulking the distal LAD. So they've used the 1.75 burr, and then this is a control after the rotablation, nothing really special. And once again, after rotablation, we failed to cross the circumflex with the Rota Y, also with the BMW, the Pilot 100, the Fielder XT. So we decide once again to post-dilate the distal left main, because sometimes it's helpful. Maybe it's a mistake, but we pre-dilate with a non-compliant 3012 balloon. And this is the control. The situation was stable at this time, and we continue to post-dilate. And of course, suddenly what should happen happened, and the circumflex was 100% blocked, and the patient pressure started to drop. So in this case, of course, we try again many times, and finally 2 or 3 operators came in the cath labs, and we could manage to cross with the CrossFit 200Y by reshaping the Y several times after a long minutes of attempt, and we pre-dilate the ostial of the circ with a mini trig balloon, 12 first, and we were planning to put the Rota Y with the microcut catheter, but by mistake, when we exchanged the Y, we removed the microcut, and so we have to try again. But we finally managed to recross and to put the Rota Y. Then we dilate the ostial circ and the ligament with Rota links, and this time we had an occlusion of the LAD. So of course, in this at this time, the patient was really in very bad condition. The pressure dropped dramatically. Fortunately, we have an anesthesiologist with us in the cath labs for each procedure. So we were thinking first to send the patient for surgery, but the pressure was too low. So in this case, I think we took the right decision to leave the LAD alone because it was too difficult to recross. The distal LAD was already blocked. We focused on the circumflex to save the life of the patient. And once again, we recross. We, of course, infuse by the same time adrenaline and so on. But it was very difficult to cross, to put stent. Finally, the XIENCE XPEDITION 2.5/18 could be advanced to the mid-cervix. And then, of course, the LAD was still blocked. We post-dilate again the distal left main with a 3.5/15 non-compliant. And you can see already that the distal circ result is not very good below the stent, the first stents. So we put XIENCE 3.5 on the left main with a body-wide technique because it was very difficult to advance the stent. And despite that, of course, the pressure was very low, 40 millimeter. You can see that the distal circ was not really patent. We had a distal dissection below the first XIENCE stent. So we couldn't cross with a third XIENCE. We had to post-dilate again the two proximal stents. And at this time, we were really close to lose the patient on the table. And despite non-compliant post-dilatation, it was impossible to cross a third stent distally. And one of my colleagues had the idea just to use a very flexible bare metal stent. He said, anyway, we have to save the life of the patient. Doesn't matter if we put a directing stent or anything. And he said, let's use the more flexible stent we have to reach the distal circumflex. So he decided to use a PRO-KINETIC ENERGY 2.5/18 that I even never used, and we could really manage to go distal and put a third stent at the distal circumflex. And fortunately, the result was okay. Of course, we left the LAD occlusion like this. So the end of the story, the patient was, of course, intubated on the table. We gave inotropes. The left main and the circ was patent, but the LAD was occluded. So he had a CPK raise and a MI, but he was discharged after 10 days. And the take-home message to me is that, of course, for distal left main, you have to be always ready for a complex procedure, even if we are, if you are in the high-volume centers. We must consider the angulation of the circumflex and the calcification that we have probably underestimate. The Rota ablation is efficient, but the Y usually is difficult to manipulate. And we use over-the-Y balloon to exchange, maybe useful, but you can see that you have to be careful when you exchange a Y and manipulate to prevent complication. Thank you very much for your attention.